Hi, my name is Josh Hill, and I'm a transplant infectious disease physician based at the Hutchinson Cancer Research Center and the University of Washington in Seattle, Washington, in the United States. And one of my research focuses in clinical practice is managing infectious complications in patients who receive immunotherapies, and particularly chimeric antigen receptor T cell therapies. And as most of you know, the use of these therapies is really increasing rapidly around the world, with a few commercial approvals now for leukemias and lymphomas, and really highly anticipated approval for a CAR T cell product for multiple myeloma, which I understand might be coming in the coming few months here. And as we start to see availability of these products, it's going to be really important to understand how to manage some of the complications that we see from these patients. And of course, cytokine release syndrome and neurotoxicity are some of the most common, really early acute side effects that are key to manage, but they overlap substantially with the manifestation of infections as well. And currently, we don't have great ways of distinguishing between the two. There's still a lot to learn. We know that bacteremias are very common early after CAR T cell therapy, particularly in patients who develop cytokine release syndrome and require management in the ICU. And then in the long-term setting, we're still learning how these patients recover their immune system and what sorts of infections they're at risk for, especially since they can have prolonged depletion of either early and naive and memory B cells, or in the case of myeloma, of plasma cells. So of course that would put you at risk for organisms that are encapsulated bacterial pathogens like we know in multiple myeloma, but also a variety of other pathogens if pathogen-specific antibodies produced by plasma cells are depleted after myeloma. And so that's a lot of where the research focus needs to be and how to support these patients. We don't know the best use and practice for intravenous immunoglobulin or subcutaneous immunoglobulin supplementation. I certainly think patients with multiple myeloma are potentially likely to benefit from those types of products if they have low total IgG and are experiencing recurrent infections. I think that's totally appropriate. But understanding when to vaccinate and what vaccines to give in this patient population will be critical. I think part of that, we really need to learn when plasma cells recover and if patients are remaining in remission, and when the rest of the immune system recovers, so that we can vaccinate these individuals. Currently, for the coronavirus vaccines, we are recommending considering vaccination as early as 3 to 6 months after CAR T cell therapy. Whether vaccination prior to CAR T cell therapy might be relevant is a key question for the field as well. And so, in the early periods after the CAR, we give standard prophylaxis during neutropenia with levofloxacin and fluconazole or micafungin. And then we give acyclovir for antiviral prophylaxis for at least 6 months to a year in these patients. And then escalated prophylaxis might need to be considered in patients who have severe CRS or are critically ill in the ICU. So a lot to learn, a lot that we'll be looking at over the coming months to next year or two as these products move into the commercial space and lots more patients are treated with them. And I think it's an exciting time and field to be in this space to, of course, see the improved responses in these patients with difficult to treat malignancies, but then really trying to refine our approach and understand how to manage these patients long term, so that once they're cured of their underlying malignancy, we make sure that we keep them infection free, out of the hospital, and healthy. And I think that's all I have for you today. Thanks for your attention.